to do that. So thank you for listening to those. And we'll move on now to the final presentation of the morning. We'll have a few questions afterwards, and we're pleased to have Dr. Erwin Vanderhoof from the Stern School of Business Society of Actuaries, who has presented in the past on some Lyme disease costs to society, but today he will focus his attention on some of the data he's collected regarding pregnancy.
Thank you very much. Can you hear me okay? Am I okay?
Yes.
I'm okay, I'm wired. We've been working with the Joint Society of Actuaries and Lyme Disease Foundation database for about 6 years now. I presented information from that several times in the past. This is sort of a continuation. We hope to continue into the future also, and to the extent to which we can build the database even further through additional responses to the questionnaire. A copy of the questionnaire is in your booklets, so if you want to, you can refer to that and have some idea what's included. We encourage people to fill it in or fill in the new version. We encourage people who aren't sick to fill in the version because they constitute a useful control group. This is your basic form. Total number of entries in the database is now 1,032. Of those, 771 have been diagnosed. Of those, 553 were female, 71%, 24% male, 4% sex was not distinguished on the questionnaire. Symptom-free were 12%, reported, about a quarter report unknown, about half. Months till diagnosis for all of the groups, 21 months. This is generally has got to be considered a group of very serious, intractable cases. I view the evidence as showing that a long time between the infection and diagnosis almost guarantees an adverse outcome of difficult treatment. The ones, you'll note that the ones who were symptom-free were diagnosed in 8 months. You'll notice also that of this diagnosed group, 27% had positive tests only, 13.5% had negative tests only, and half the group had both positive and negative tests. 70% remembered a bite, that's a high number. 45% remembered having a rash. The question of the cost to society has come up and was one of the original reasons this study was done, the database was completed. This shows information about the cost of this disease, including the cost of search, lost income, medical treatment before and after diagnosis. Let me move down a switch. 771. Number of MDs. This is the number of doctors who were required to make a diagnosis. This is the number of months. For the total group, was on the average 5 doctors were required to be visited before a diagnosis could be made, and it took 21 and a half months. The total cost for this intractable group was $67,400 on the average. If we look at months to diagnosis, we split it down. The diagnosis was in less than 7 months, between 6 and 13, and over 12 months, you can see the way the costs go up. If you look at the rash and bite situation, we find that even though the rash is generally considered diagnostic, it took 5.8 doctors to make a diagnosis for patients who considered that they had a rash. For patients who had a rash and remembered a bite, the situation was slightly worse. It took slightly longer and it took almost 6 doctors. I have pointed out in the past that that's almost enough to carry a cost casting. 6. The tests really didn't seem to matter very much as far as that was concerned. And the most unfortunate thing, 77 cases had positive tests only, a rash, a bite. It still took 3.4 doctors, 16 months, and $48,000 for the treatments. You notice the symptom-free cases came down quite differently. The positive rash and bite cases were 1.5 doctors, that's 1 or 2, that's not bad, and 3 months to get a diagnosis for the cost of $11,000. So the relationship between the period it takes for diagnosis, the failure of some doctors to recognize this extreme case of a positive test, rash, and bite, implied to me that the costs, the financial costs, are very much dependent on rapidity of diagnosis. You know, this is sorting everything by number of doctors it takes to do a diagnosis. And you notice that the number of doctors involved and the period just go up monotonically. The costs go up monotonically except for a couple of cases. In these 2 cases, there were very high costs involved in a small number of cases, and that drove it up. There were other costs besides strictly financial costs. In the database, mental anguish, 71%. They claim non-cash offices about 68%. Permanent damage, 41%. Job loss, 20%. School time loss, 18%. 19 divorces and 7 deaths. 5 autopsy. It seemed to me that going forward on this, one useful thing would be to better define, if I could, through the use of this database, the symptoms, because Lyme is a clinical diagnosis. And the questionnaire provides for the number of symptoms, and there's a reporting of frequency and severity. And we moved the numbers around a little bit. I added everything from the way it shows up on the questionnaire. So the grading of severity runs from 1 to 5. The grading of frequency runs from 1 to 5. 1 is never, 5 is continuously, all the time. And then severity would be, 1 would be nothing in particular. 5 would be absolutely excruciating, as bad as you could get. So I just multiplied the 2 numbers together for each symptom, and that gave me something called intensity. And you'd say somebody who had a 16 on intensity, well, how could they get 16? They could get it if it was almost as bad as it could be, almost all the time. Or almost as bad as it could be all the time. Or as bad as it could be most of the time. These are the things that you would expect a patient to report to a doctor. And so I got the intensities for all these symptoms. I think, can you see the back all right? Yeah, good. I've had bitter criticisms about my overheads in the back. But I don't have anything that has to be pretty showing colors, so I can get away with it. Also, I don't like to leave things till the last minute, and this way I could do my overheads on Friday before I came here. And I still worked out. General symptoms, I did this average of this, what I call intensity, for 2 groups. The ones who were diagnosed, the ones who were not diagnosed. Remember, I had about 260, and the total surveys weren't diagnosed. And we see there's a nice difference. Profound exhaustion, that's something that's knocking people out on the average. A profound exhaustion for the not diagnosed, occasionally get tired. Recurrent fever, that's pretty high. So the contrast there is very nice. And we go down, we see benign nodules. We had some of that report in the Lyme diagnosed group, some discoloration, and some of that in the diagnosed group also. So that's a pretty nice comparison. Then we said, what about males versus females? How do the symptoms show up for them? Well, that looks different. The females seem to show more severe symptoms. Is that really different, or are they just the same? Is it accidental? I couldn't tell, really, whether that was an accidental difference. And then I looked at another group. Here I have a group that is broken down slightly differently. This is the group that had a bite, a rash, a positive test, and no negative test. This is the group that was diagnosed, but didn't have a bite, didn't have a rash, and had negative tests and no positive tests. So this is the group that was most clearly inclusive, fitting the criteria for having Lyme disease. This group was the one where this diagnosis would have to be considered a little bit shakier. And then many of the things are the same. Some of them are different. The headache is more likely over in this group, the intensity. Are they the same or different? So I was concerned about whether these were real differences or whether they were simply appearances, statistical fluctuations. Now I get into a little bit of hard stuff. I'm going to talk about statistics before I go into the next step. Supposing I have two soccer teams I want to set up from the East High School and the West High School. And I've got a bunch of boys coming in from each of the high schools. I'm going to take a sample of 10 from each of the schools. And I'm going to say, well, are these really the same or are they different? Well, supposing I measure the west side, and the west side are all exactly 6 foot 1 inches, and the east side is all exactly 6 feet inches. Because there's no variation in either one. I'm going to say those are different. I'm not sure why or how, but they're different. On the other hand, if there was a lot of variation in height in each of the groups, and there was only a difference of 1 inch in the average, I'd say, well, probably they're the same. It's just, chance fluctuations. So there are 2 factors involved. Is there a difference? Second factor, is there a lot of variation within the groups? If there's a lot of variation, then a small difference doesn't matter. Supposing I say that my potential for soccer is based upon the height, the weight, the age, say the previous experience, say some other physical measures of strength and endurance. I have a whole lot of different measures for each of these groups. How do I compare them all at once, keeping in mind that height and weight must be related, and height and weight and age are probably related? Then it gets not to be a simple comparison, but a complicated comparison. There's a way to do that, called a Hotelling T-squared. I'm breaking up my group into diagnosed and not diagnosed. Probability that they're same is 0. Females, males. Probability that they're same is 0.2%. So I've got now a way to measure whether all 55 of these things add up to 2 groups that are the same or 2 groups that are different. Diagnosed answers follow, not follow. We had a follow-up questionnaire, and we said, all right, is there swelling? If I'm going to apply the results of that follow-up questionnaire, I should be able to say that this is the same group, or substantially the same group as the whole group. What I do there is I look at the all of those symptoms on the people who answered the questionnaire and the people who didn't answer the questionnaire. And I say, is there a chance, what's the chance of the same? 38%. Well, on these types of tests, the normal thing is to say if it's less than 5, you say they're different. So at 38, you'd say the people who answered the follow-up questionnaire is the same as the one who didn't. Let's look down here. People who filled out a doctor's office and the doctor's code, and people who didn't. These presumably had some coaching from the doctors to how to fill it out. These people just probably came in from the supported. 61% chance are the same, so they're the same. Minnesota and Wisconsin versus not Minnesota and Wisconsin. They're different. Some comment has been made about a different strain. They apparently produce a different pattern of symptoms. Diagnosed pregnant females, diagnosed females who were not pregnant. There's an 84% chance that all the symptom patterns in those two groups are the same. I'm coming to the end of the pregnancy part. Before I go to the last slide, I'm going to show you a slide that you wouldn't expect, and it's really terrible. This is really horrible. But I wanted to give you one, I wanted to use this rather than something that looked nicer, because this is an actual page from the Statistical Abstracts of the United States. I'm not trying to sell you anything on this. This is what the page says. We're talking about infant, maternal, and neonatal mortality rates, fetal mortality rates. 70 to 93. That was the latest issue of the Statistical Abstracts I have. This says deaths per 1,000 live births. This is infant deaths, 8.5. Fetal deaths, 7.4. So you add those two together, you get a number that's sort of like 1.5%. That is 15 per thousand would be 1.5% of a group. This is as clean a source of data as I can get. The questionnaire had questions about women who were pregnant with Lyme disease. These pregnant women, 45% showed the rash, 50% of the 45% of the non-pregnant women showed the rash, 50% of the pregnant women showed the rash. Positive test 27, negative 12, 11.1. Positive, negative 52, 46. Number of MDs. Diagnosis months for the pregnant women was 33 months. Now I've shown on the basis of the pattern of symptoms that the pregnant women and the women who were not pregnant have the same constellation of symptoms according to this hotel and T-square test. They also have the same pattern of rash, no rash, all the rest of it. What were the results? Of the pregnant women in this study, there were 55 live births, 19 miscarriages, 4 born dead, 3 died shortly after birth, total of 81. 26 adverse outcomes, 32%. Of the women who say they were treated for Lyme disease, 21 live births, 3 miscarriages, 12.5% adverse outcome. Of the women who say they were not treated and pregnant, 34 live births, 16 miscarriages, 4 born dead, 3 died shortly after birth, 23 adverse outcomes out of 57 total, 40%. The figures I showed you from the Statistical Abstracts of the United States say 1.3% would be expected. It is perfectly possible for you, someone to tell me that my statistics are not very good, that there's some bias in the sample, that there's some bias in the people who answer the questionnaire. There is, as far as I'm concerned, that is an inadequate explanation for the difference between 1.3% and 40%. It would seem on this basis, unless an awfully powerful explanation can be developed, that Lyme disease is a most severe risk factor in pregnancy, and this has not previously been reported. There's a separate pregnancy register that we carry. I haven't had time to analyze it yet. 732 cases, 148 would report an abnormal outcome. I consider 148 to be a very high number. I will tell you also, look, I read the characteristics of the abnormal outcome, and well, my wife and I found it very difficult because it's difficult for us to read about problems with babies, and so many of them. I will also point out, finally, in closing, that one of the posters upstairs talks about infected cows. What was the stillbirth rate for infected cows? It was 20%. So it seems that a simple animal model also confirms the same high-risk evidences for Lyme disease. I talked to you about the basis of the study. I've spent a little time on a statistical methodology frequently used in biology, but not frequently used in medicine, which allows you to at least put some credence on two different groups, not being the same. There's not a bias in the answer, say, a question or follow-up. And finally, I've talked to you about what I consider very troubling information in connection with the risks of pregnancy for women with Lyme disease.
Thank you very much, Dr. Vander, for a very enlightening picture of the costs, and especially with the new information regarding the pregnancy data that I think need to be pursued further. Will the speakers from the last section come up, and we'll have a few minutes for some questions. And please, those of you who have your CME forms, please continue to fill out your evaluations and hand them in at the end so you get the credit. And then we will resume at 1 o'clock fairly sharply so that we can move on with the program. Dr. Miller.
Erwin, I'm kind of fascinated by your presentation, and I just have one question I wanted to ask. Do you have any idea what dollar percentage insurance companies paid for all of this?
I did one study on insurance companies, because I have data on whether they paid or not. And as far as I could tell, there were no insurance companies that never paid, and there were most of the insurance companies failed to pay or argued about it sometime. As far as I can tell from talking to people at support groups, if you go in, present a claim, and the insurance company says no, and you go away, they will be perfectly happy to let you go away. If you persist and have your doctor write letters and all the rest of it, in almost all cases, they will eventually pay. And since I worked in the insurance industry for 30 or 40 years, I'll give you a little argument on their side, and that is, since there's no clear evidence as to whether people have Lyme disease, when they're cured, or what protocol works, insurance companies really hate to pay money on that. If you get them to the stage where you say, all right, here's the disease, here's what it'll cost, and then it'll be over with, it will be much easier. But that's, once it's well defined, they're just going to charge it to the employer, and everybody will charge the same thing. When it's ill-defined, they don't know what they're doing, and they know it.
Next question.
This is also for Professor or Dr. Vander.
Many times.
I'm a chronic Lyme patient, and my girlfriend is a chronic Lyme patient.
I'm sorry.
Yes. I and my girlfriend are chronic Lyme patients.
Yes.
And it's difficult for me to say this in front of my girlfriend's dad, but we've been discussing having children. Is there any information beyond death rate or anything that you're considering doing that would show possibility of infection in healthy babies and symptoms?
I am not an MD. okay?
Can we extend that question, Erwin, to include, do you have the information from your survey as to how long before did the pregnant women have the Lyme disease as opposed to
I do have some
having it
information.
right during?
I haven't done that analysis yet. The best thing I can say is, but Karen, my daughter, has been a long-term Lyme disease sufferer. Christy is absolutely fine. I can say, however, that it would seem to me to be necessary to have some treatment during the period of pregnancy, because it seems as if cases where there was continuing treatment during pregnancy, not a reasonable possibility. Those that were not treated, I think that's very dangerous.
I think you raise a dilemma that we have in medicine and in obstetrics in particular. Is it much more common, or should it be thought that a woman only acquires Lyme disease during the first trimester that would be a threat to the fetus during that period of time, as is traditional for toxoplasmosis, for cytomegalovirus, for rubella, or does a person with a previous history, and that's where it comes into treated or untreated, is there a risk for reactivation during pregnancy or seeding of the bloodstream such that the fetus may get infected? And we need more information in that regard, and I think it deserves careful scrutiny so that you and a lot of other people can have meaningful answers to the issue. What happens practically is that patients during the first trimester end up getting treated more than they don't get treated, and the issue is how long do you keep it up for the entire pregnancy. I think a lot of people are comfortable with doing it during the first trimester and then judging on symptomatology, but you know your antibiotics are fairly restricted at that point, basically to amoxicillin or a cephalosporin antibiotic. We'll come back to you in a minute there.
Dr. Vanderhoof, that was a wonderful of course. Is there a reference where you're going to be publishing that, or did I miss it?
The question is, are you going to be publishing that?
Yes,
Is there a reference?
I want to publish that. I do have a version which is being submitted to the journal for publication.
It's coming now.
We've been following pregnant women in our practice for over 10 years. I don't have the exact number, but I know it's well over 200. And in most of these cases, when we discussed the options with the women, they opted for treatment through the whole pregnancy. There were a few exceptions where they wanted to wait until they got symptoms, but I'd say the majority of patients were treated through pregnancy. We did use quite a few courses of azithromycin through the pregnancy, no problems. And from the 200 plus patients we had not one bad outcome. I don't know how many of them are included in your study. I know some of them did fill out your forms, but at least from our experience, I think that there were some that weren't treated through the pregnancy and also had no adverse outcomes, no miscarriages, no fetal death, or anything. So we're talking about a sample of over 200.
Okay, next question. Treatment. Thank you for that comment.
I just wanted to comment on our bovine study showed transplacental transmission, but did not really address whether or not the stillbirths were due to Borrelia infection at all. We can't make that statement. I wouldn't make that jump at all at this point.
The bovine study showed upstairs simply stated that there were 4 out of 15 stillbirths.
Stillbirths, and we did culture, but that doesn't mean that the Borrelia infection.
For humans, you've got a number from the statistical abstract, which was up there, which says 1 or 2% for the Lyme disease cases. In our study, it was about 20%. Just so happens it's the same number. I don't think numbers are always accidental.
Dr. Ziska had presented a couple years ago the results of a prospective study. All of them, however, were treated, and they were small numbers, and the tissues did not have any evidence of of infection as judged by PCR and culture as well as histology. We have time for maybe 2 more questions.
Question for you, Dr. Donda. Would you consider a documented Herxheimer's reaction as an opportunity to test the efficacy of corticosteroids?
Well, there's no such thing as a documented Herxheimer reaction. I mean, you're assuming that, let's just, for argument's sake, just agree that you're saying a worsening in symptoms are due to a confluence of events that involve cytokines, a variety of host factors that your question then addresses. Can we ameliorate some of the symptoms by using things like steroids? Because traditionally patients are not benefited by the non-steroidal anti-inflammatory agents, your ibuprofens and such. I don't know, that's an interesting question. It would be good to have some initial anecdotal information that somebody did that and found it to be helpful in order to set up some kind of a trial. I think it would be very difficult to control the trial, but nonetheless, that's an interesting point. Thank you for raising it. Excuse me, there's another comment.
When you look at the literature, there really isn't much literature about steroids and during antibiotic treatment of Lyme disease. It's interesting, there was an article in I think it was the Journal of Infectious Disease, where there was a case study of somebody in the Black Forest region who did develop Lyme disease. It was PCR positive and basically presented with dermatomyositis and was on treatment for dermatomyositis with steroids. And the initial treatment was a treatment failure, and the patient was retreated without steroids and was a treatment success. So I think there's a risk of really not being able to effectively eradicate the organism by using steroids. So if they're used at all, they should be used when the patient needs it for symptomatic relief, or perhaps if it's really that there seems to be a medical problem that needs to be ameliorated directly with steroids at that time. But it probably should not be recommended that it be used in a general way with Herxheimer's or any sort.
I just say the same thing looking at Dr. Straubinger's data, dogs. I don't know if you presented this, but clearly it's going to proliferate the infection. So what's the point? Why take a risk? So I think I don't think you want to gather too much anecdotal data. If someone accidentally does it, but I think he's just asking for trouble for a small period of time. It's not really worth it until you.
Well, we have that information from infectious diseases, treatment-based flu, otitis, meningitis, that suggests that maybe co-steroid treatment prevents some of it, but I think these points are well taken. 2 quick questions, and then we have to finish. Hold it, there's one more.
I'm interested in pregnancy, breastfeeding, and Lyme disease. I know that our local hospitals routinely check for other diseases, and I'm curious whether or not you think it's appropriate for routine Lyme disease checks for women that are pregnant in endemic areas, and also whether or not you know of any tests isolating the spirochete in breast milk.
I can't answer that one, but I give you the facts.
Yeah. I think that's a good point to begin to raise to state health departments to begin surveys where they get information that uses better testing, Western blots, details, not traditional criteria, but any criteria to look at specific reactions, plus PCR DNA testing in a sampling of it to begin to address that question.
I think the problem that exists with that, once again, is if you have a patient who has a negative test, that may not mean that they don't have the disease. So therefore, we have to be careful not to put anything into effect that might actually unfairly, rigidly structure some people or providers into thinking that they now have an answer that the person does not have disease. I think it depends as the person, just like every other patient, they have to be evaluated for the possibility of in an endemic area.
Dr. Can I ask you a question?
on that same matter?
No.
Well, hold on, Dr. Miller has this, and I think the time is getting late.
Very quickly, I really feel obligated to comment on the Herxheimer reaction at this point, since it was...
Did you help describe it, Dr.?
It was discovered in syphilis many years ago, maybe 50 or 60. So I just want to make one comment. It really is contraindicated. What they used to do in the old days is to take killed organisms and those that they weren't too sure of diagnosing, where they didn't know whether it was syphilis or not, and try to produce a Herxheimer early on by giving killed organisms, and in many of the patients they blew out the aorta. So I think it's very important not to fool around with an exacerbating a situation where we really don't understand the mechanism of Herxheimer reactions, and I think in this case I'm obligated to tell you that this can happen.
Thank you for those comments. One last question.
Just a question, is there any way to determine what we hear about the permanent damage that Lyme disease can cause? Are you talking about permanent damage to the joints, or are you talking about neurological? And how do you determine what
someone's permanent damage is so that they're no longer on antibiotics? Or do you just, if you have any kind of symptoms, do you stay on the antibiotics?
I guess you're raising a key issue, and I don't know whether other individuals are better qualified. It is, are you left with some kind of damage? How reversible are the symptomatology? And from my perspective, that's still debatable. The optimistic view is that a lot of this is reversible. There is clearly some joint damage that has occurred in long-term sufferers that is not reversible. But I welcome input from others. Maybe we can do that in the next question and answer period. So I'd like to maybe make one brief.
Just quickly on the patients that we had, a good number of people had disease for a good number of years, and we found that they did have reversal of many of their deficits. It's very difficult to determine without biopsies or understanding what's going on. All I can say is that a good number of people can be helped, and those who have no more microbiological proof of disease, if we really get a good test and continue to have persistence of symptoms without increases, maybe not associated with fluctuations due to hormonal effects, then we may consider that permanent damage. I think we want to take an optimistic viewpoint as much as possible to say we want to look for a cure for the disease, and we would like to see that all patients, or the majority of patients, are not going to be left with residual permanent deficits due to damages done by bacteria. So,
okay, that wraps up this morning's session. I'd like to make a few quick announcements.
Can you turn this on? Thanks, guys. Actually, one of the things I wanted to do, in case anybody leaves early today, I wanted to thank the Equitable employees here at the Production Center for a great facility. There are a number of people you don't see behind the scenes, up there in the booth, and behind the stage who've really done a fantastic job. I want to make sure we thank them. I also want to thank real quickly a couple of volunteers from the LDF's New Jersey Coalition, Roberta Beth and Gordon Sue Greenberg outside. We really appreciate their help. Try to get your lunch and get back as fast as possible. We do want to stay on schedule. If you can, please come back by 1 o'clock. We know it's going to be tough, but please try.